Hi, my name's Lenore Boris. I've been chair of the PAC Executive Committee for the last 5 years, actually. And I welcome you today to the 2020 stakeholders meeting. It's not just the year end, but it's also kind of a wrap up of the 5-year journey that we've been on. Before we begin the presentation, I need to cover a few housekeeping rules. First of all, the meeting is being recorded. Just so you know, it will be available on the CCN website after the meeting. You will receive an email notification for everyone who has registered so that you know when it's actually available. You will also, after the meeting, be receiving a survey link to provide us feedback. There is an Zoom toolbar at the bottom of the screen. You might have to move your cursor to have it appear. When you do that, you will see that there's a Q&A icon. As a participant, please put questions into that Q&A. The participants will only be able to see your own question. Panelists will be able to see all the questions. The panelists and a few of the CCN staff people will be monitoring the questions. They will try and answer them during the presentation or at the end. If they don't have time to answer all the questions, they will be answered after the meeting and responses will be made available on the CCN website. The chat, that's another feature you find on your toolbar. We have enabled the all chat feature, which allows a chat from the audience to everyone or to just panelists. If you click on the attendees, you can actually see who's on the call. There will be several audio clips scattered throughout the presentation. We have tried to maximize the sound. However, there are a few segments that you may need to adjust the sound on your own device to ensure that you can hear it. All the video clips will be available on the website, which will allow for greater clarity. Finally, we are monitoring the time. Oh, for some reason it says chat is disabled, so we'll see about getting that fixed. We will be monitoring the time to ensure that we can end on schedule. Oh, now I'm told the chat is up, so. All right, let me move on then to start the presentation. The title of this presentation, Celebrating the Journey, Past, Present, and Future, was selected with great care. We have been on a 5-year journey together, and we're here to celebrate that journey and to highlight some of the contributions you have made and some of the successes that have occurred. Clearly, so much has happened in 5 years. We can't cover everything, but we wanted to give an acknowledgement to the hard work you've been doing and to give you just a sense of all the things that have been accomplished in these 5 years. We also wanted to celebrate the present, where we are today, how we've come together and what's happening. And then we want to give a sense of what the future holds. Our work is not yet over. We need to still hang together to continue the transformative work that has occurred over the past 5 years. We knew going into this that the journey we were on would need to be longer than 5 years, that the work of transforming a healthcare system is big, and there are many things that people had to learn and come together to try and make the transformative changes that we wanted to. As part of that, giving you a vision for the future, we'll provide you a strategic plan update. I first want to thank the CCN board members. You see them listed. They have worked tirelessly behind the scenes. They often receive packets with more than 100 pages for them to review before they ever get to the board meetings. It's a lot of work, a lot of commitment, and we want to thank them for their effort. The same is true for the people who have been on the PAC Executive Council. These are people who were selected to represent you, the stakeholders, by region, by skills, by area of work, to be the voice to review what's happening, provide feedback to the CN staff, and feedback to the board of directors. Again, it's been a big time commitment for them, and we want to thank them. We really value their work and the contributions that they have made over the last 5 years. I think it's part of the reason we've been able to be flexible. With that being said, I would like to introduce our board chair, Kathy Connerton.
There, I think I'm on.
Yes.
Good morning, everyone, and thank you for the privilege of being able to present today to you just for a few moments. You can see the title slide, The Journey 2015 to 2020. I had the pleasure of joining CCN in 2015. And to say it's a journey is really an understatement. It's been much more than just a journey. I think it's been a family. It's been a group of individuals who started out not knowing a lot about one another, maybe nothing at all. And today I think we are in very different stead as a result of the work that we've done under this pilot project and as part of CCN. So first, I want to take a moment just to say a few words about 2020 and then maybe just a few reflections in hindsight from 2015 to 2020. You know, 2020 for all of us has been an incredibly unprecedented year for all of us personally, and then for the organizations that we represent and have the privilege to lead. We're in unprecedented times. We don't know what the next day is going to hold and what we're going to have to do to be able to champion it and to be able to be here for the people that we have the privilege to serve in our various communities across our 9 counties. But I want, on behalf of the board, to thank each and every one of you, and to every community-based organization, and to every healthcare system in our region for resilience, for courage, and for commitment. It's not without a lot of that we've been able to get through this year, and that you have stayed very relevant and so important, especially to the poor and vulnerable in our community. Without you, there would have been such a gap in service that this year would have been much more difficult and much more challenging than it already was. So thank you. Thank you from all of us. And I want to say a personal thank you from a healthcare system standpoint. While the healthcare systems have gotten a lot of attention, and understandably so, given the nature of the virus and what has happened in the last 9 months, it's the folks with boots on the ground each day that are taking care of people in their homes, taking care of the issues and the social determinant barriers that are presented before them in times like this, and not walking away and being there for them. So thank you, thank you, and thank you. And our hope is that soon, with the promise of vaccines, that we will all be able to return to some segment of normalcy. But let's take a second now and just look at 2015 to 2020. When I was asked recently what I thought was most impactful about this journey, I said that for me and for our healthcare system in general, what it finally did was present a key. And the person asked me what I meant by that, and I said a key to finally unlocking how to make healthcare and becoming more healthy and well in our daily life a real reality. For decades, healthcare systems have tried to change healthcare status. And we've had pockets of success. We've done things great. But what we've never been able to do is to really mitigate the social determinants that create barriers for people to really stay healthy and well. So this journey that we've had with you has been a real learning for us, a real learning about all the services and vital things that you do each and every day to take care of people in our community that provides the key to unlock that question. We saw it personally here at Lourdes in our cohort management pilots that we engaged in with various community-based partners, that in a very short span of time, we were able to show real measurable outcomes in changing the health status of people in our community who before that were not able to get there. It has taught our healthcare system that there's a new way to operate, that we can't operate without you as a key partner, with you walking alongside of us and teaching us a new way of doing things. And likewise, hopefully we bring some new knowledge also. So for that, I am eternally grateful, and our board is eternally grateful. We are just starting to understand it. And when I think about what we're just starting to learn, it's all the things that we've done from 2015 till now that have given us that base of knowledge to be able to take this forward. You know, when I think about when we first all came together, we brought all these health systems together that never really worked together before, and really had no reason to work together before. You know, we existed together in our communities. We probably constructively competed at some level, but we never really worked together. And it gave our associates and employees a way to work together, to come together in a common bond. And that was an incredible benefit. But then we added in all of the community-based organizations, and you brought on our board, and you brought in all the meetings that you've had that all roll up into CCN, a different lens that have taught us so many wonderful lessons. So as you think back today and you see the accomplishments, and Mark talks not only about the accomplishments, but the strategy to go forward, understand that it's those 5 years of learnings and listening, more importantly, that have led this way. And that is the work that each and every one of you have done. So once again, on behalf of the board, I want to say thank you. I want to say thank you from the bottom of my heart in my own institution, but also for the privilege of leading the board for this wonderful organization. I want to thank you and wish you all a very happy holiday. Thank you, Lenore.
Thank you, Kathy. I just want to remind you all why we were on this journey the past 5 years. This is right from the Department of Health website, the DSRIP goals. So it was to reduce the avoidable use of hospitals by 25%. That's a significant amount. It was, as Kathy indicated, an effort to pull together the community at all levels of collaboration. The community-based organizations that deal with social determinants, the hospitals that provide acute care and have outreach through their primary care clinics. It was an effort that would lend itself to system reform to improve the communication between partners, to improve the understanding of the role each of the organizations play in maintaining the health of individuals and community. Reform was always in our discussions a guiding principle as we tried to move forward to create a healthcare system that's more responsive to individuals and therefore improves the health of the whole community. The safety net providers, the providers that had at least 25% of their population involved in Medicaid, were required to work with other organizations so that we could make the system transformation, the clinical improvements, the population health improvements that were needed. Although DSRIP was focused on the Medicaid population, we've always understood that many of the changes that have been occurring in providing healthcare in our community did spill over into people's whose healthcare is paid for by other means. And that will continue in the future. Why did you all get involved in this DSRIP process? I recall being at a public health department, community health steering committee meeting when Robin and Lisa came and said, there's this new opportunity to help bring money to our region to reform the healthcare delivery system. So why did you get involved? We did interview 14 partners to ask them this very question, and we have now for you some of their responses. Partner testimonial.
This program was launched back in 2014, 2015. The main objectives, the two overarching objectives, were to lower high-cost admissions, normally readmissions, and to lower the use of the ED. Both of those utilization trends tend to represent an insufficient community-based care system, and that throws people into overuse of high-cost care. So those were the overarching objectives of bringing about the DISRIP program over a 5-year period. And the theory behind everything was that if you could build a network beyond the boundaries of an individual provider and integrate healthcare providers with social care agencies, that those outcomes could be achieved. Was that someone, a payer, in this instance, Medicaid, was willing to pay for the effort to set up the infrastructure for this highly integrated delivery network and the population health tools that we would use to better manage the network. I think that was the exciting part. Up until that time, no payer was offering dollars for infrastructure build that was going to be necessary for value-based payment. So, truth be known, the original prodding for coming together actually came from the Department of Health and Jason Helgerson. So the Rural Integrated Network to the north was a small PPS that they felt in the long run would not have the number of covered lives necessary to be able to thrive. And so when they responded to our initial application for planning funds, they told the Southern Tier PPS that we had to engage with the Rural Integrated PPS. But they never told the Rural Integrated PPS that that was a requirement for them to get their planning funds, which made then the coming together just a tad more difficult. And so when finally the communication channels opened up and everyone understood that the desire was for these two PPSs to come together, I think fundamentally we all understood that you can't do that in name only because someone said to do it, that you had to generate the will at the grassroots level for something like that to happen. Now, this juncture came about at a point in time where we, the Southern Tier PPS, were already marching down the road of building out our plan and the programs that we would want to engage in and had an agenda. But the reality was, so did Rural Integrated PPSs have their agenda. And so we took a very big breath and did a very brave thing. We set down our agenda and we held a combined meeting here in Binghamton with over 100 people at it from both PPSs. And we re-examined what we had in terms of data to inform what we together needed to set as our programmatic agenda for district. And I think that fundamentally changed the course of things, because the message right from the start was it was going to be inclusive. This wasn't a big PPS taking over a little PPS, and that everybody's voice mattered.
Well, hello, everyone. Good morning. Nice to see you all virtually. I did go through the list of participants just now. It's good to see so many of you joined. I want to take a moment and give a report out on funds flow. We like to do this at a high level at each of our stakeholder meetings. And in reflection to where we started, I remember setting one of the initial budgets, and we had to just allocate a non-accounting term to our budget called the haircut. We just didn't know what was possible under the terms of this grant. It was so large and had so much variability. But I'm happy to announce through our current financial statements, not only have we earned, but we've deployed $128 million out into the community. What's hidden underneath this and all the financial statements and ledgers is that over 79% of that went to a category that the state would call CBO, which is basically non-hospital inpatient. So outside of those PMO and non-hospital IP categories, 79% of that went into investment in delivery of care at frontline locations. And when you look at this, you see a small component of that was speed and scale, was something that we were focused on, and our midpoint assessment said you have to really emphasize around. We did deploy a lot around speed and scale, But if you look at the other categories, a wide range of initiatives. Some of these are ones that that we made up. We cumulatively, or the whole region, came up with frameworks for innovation. CCN actually just made the opportunity available. Everybody wrote their applications, but the community, you guys helped us deploy metric improvement pilots, the cohort program. These weren't in the roadmap, but were what was needed specific to our region. And I don't think that you can go through this without emphasizing that there's been millions, just on the bottom line, 14.3 in additional IT infrastructure, raising the bar of infrastructure to support VBP performance ultimately. So lots more to do, lots more that we could have done, but this is phenomenal. I mean, add the 14.3 additional IT with 16.9. These are big lifts, and there's some things that we're going to go through. You're going to see the outcome of some of this today. In particular, having 6 of our skilled nursing facilities go live with telehealth services last year was so timely. So this is the report out. I remember absent the haircut, this was very, very generous for this point in time. So we'll go through more of this in the future, but I just wanted to point out the magnitude of resource, the varied programs that these resources have gone to, and also emphasize that target, what we set out as 80% of the funds that we distributed wanting to go out to community partners. As of our current financial statements, we're at 79.11%. So we're right on target with that metric. So thanks so much to everybody. There's a lot that goes into reporting the data and managing the invoices, but this has been a phenomenal work, and compliments to the CCN team for continuing to do weekly check runs to make sure that these dollars go out in a timely basis. Lenore, I'll hand back to you.
Thank you, Mark. As people can see, involvement in DSRIP did mean a flow of money into our region to help with that transformation. But what have been some of our greatest successes? Before you, you see a word cloud that highlights the significant features of the journey we've been on. Collaboration, clearly, what we have learned about each other and our contributions to the health of individuals has been enormous over the past 5 years. We did have a healthcare system that organizations did not talk to each other. They didn't know what each other meant, which meant that patients, people seeking services, received things piecemeal without the kind of collaboration and coordination that we hoped for. This was transformative for our region and really is the foundation for improving healthcare in our region. Innovation, as Mark said, was not prescribed by DSRIP, but it flowed from your suggestions and from the efforts to really try out things that might prove to be a best practice, that might really be a cost-effective way of providing care in ways that hadn't been tested before. New solutions to the problems that people in our region face in receiving care and dealing with their health issues. And then learning. We've all learned both about each other, but also very valuable things like value-based payment and contracting and other business type foundational pieces for us to be able to move forward and continue this journey. I'm going to now introduce some more partner testimonials that will speak to the successes that we have experienced.
I think by doing the FLOW program, fitness, lifestyle, and overall wellness, having to track every single event, like every time I gave a child a fitness tracker, every time we delivered a farm share to a family, every time a youth earned a bike, we were tracking that, and then we were reporting on it. And that hasn't been our usual practice. And that's really helped us grow in that type of thinking, is pay attention to every detail of what you're doing and then report it. back, and also then tracking families down and tracking youth down to complete their survey in the beginning of the program and their assessment, and then complete a survey and assessment at 6 months and 12 months was challenging, but also very useful to gathering the data and finding out how we were progressing with the program. And I think that really kind of sets us up for the future of value-based payment. And then even by the time the cohort program wasn't quite over when we put in for our innovations grant. And as we thought about our Family Now innovations program, we took a lot of what we had learned from Care Compass and the cohort program, and we made that part of the Family Now program. And so it's like, it's already started to affect us. It's the future, but it's also the present of what we're doing.
Training. We developed the training program, and we trained the health coaches. And I felt as though we came up with a very effective training to get people prepared to go out and do the work and to partner with the hospitals. So I felt as though that was definitely very successful. And then the other thing, through the work that we did with the low-income housing units, we identified that health literacy and stress accounted for 80% of the negative impact on health outcomes with the residents. And I was able to become a master trainer with health literacy, and we trained all of our staff in health literacy, also in motivational interviewing, and that really helped the staff work with our residents in a different way. So I think Care Transitions was very powerful, and then health literacy came in and supported the work of Care Transitions and made it. I have something that I wrote down. If you apply health literacy to the principles of Care Transitions, you have a great winner, is the way I worded it. And then the other thing, as far as the success, Care Compass Network supported us with funding so that we were able to achieve an interface between our EMR system and a program called Picture RX. And what that is a program where we can produce a medication summary for our patients that's health literate. So that medication summary is in a picture format, and it's plain language, and it helps our patients understand their medications better so that they can better self-manage their care. So I think those three things have been our really success stories. I think it comes down to the programs gave us an opportunity to gain data. And so if you have data that shows the results, then you can prove the value of your work. So we tracked a lot of data. We tracked if our teaching was effective, if people understood their medications better, if they went to see their primary care physician more frequently, if they understood how to do self-care. And those numbers improved all throughout the project.
The Rural Health Network of South Central New York had a HIPAA-compliant access database, but we really needed a more robust care management platform to document our activities with clients across the agency. Was our ability to better record our evidence-based interventions, starting with screening and assessing individuals, recording where we put the patient activation measure survey results. We integrated our own social determinants of health screening tool, which is just a couple of brief questions that replaced our old healthcare access intake. We also were able to get a bird's eye view of the Care Compass Network needs assessment through our 5 cohorts that we were involved in. So we could really look one-on-one at individual health coaching and what we were doing with clients across our programs or within any specific service line. but we could also look at small group interventions or our fruit and vegetable prescription program or our chronic disease self-management program or Walk with Ease for physical activity. So it really just gave us a better 360 view of each individual client and then also different populations of clients. A really big benefit is that it's given us a way to report to our clinical providers. So one good example is with the cohort management program that we did in collaboration with Lourdes Hospital, where we had a community health worker embedded in their Lourdes 303 Main Street primary care practice. So although she had to be in their electronic medical record and in their scheduling record, she also was in the GSI Health Coordinator or Meta Decision, as it's now known, platform. So we were able to give Lourdes some really robust reports for them to then roll up and then kind of match out to the clinical outcomes. So we really have a better way to document the inputs and the outputs with any client or any client population that we're working with, and then report to either funders or care.
You might already know him, but from educational programs he's presented. But let me introduce Dr. Wayne Terrace, the Chief Medical Officer for Care Compass Network.
Thank you so much, Lenore, and good morning, everybody. Almost good afternoon. First of all, I would like to echo what Kathy Connerton said and express my heartfelt thank you for all the good work you do. You know, back when I was in training, the healthcare establishment would have me believe that 99% of outcomes were due to all that complex clinical care that we provided. But those of you who've seen some of my other talks and the pie chart that I show, you know, it's estimated about 10%, maybe 20% of health outcomes are actually due to clinical care. And then 40% actually due to social and economic factors, 30% due to health behaviors, 10% the physical environment, 10% genetic factors. So why I tell you this endorses the importance of the coordinated team approach that's the foundation of our CCN programs and initiatives, integrating clinical and social care, so important. So prior stakeholder events have done a deeper dive, as will future events and presentations. And our team is actually in the process of developing some very detailed white papers evaluating each CCN program. Today, however, I will be reviewing high-level aggregate information from the last 5 years. Next slide, please. Our programs have had a tremendous impact, not only on Medicaid members attributed to CCN, but all Medicaid members in the region, and in fact, all residents of the region. Next slide, please. Through our collaborative efforts, we've had an incredible impact on our region. Programs. Over 90,000 attributed Medicaid members received more than 450,000 services over the past 5 years. Funding. $128.2 million directly benefited partners, including $113.9 million for speed and scale projects, cohort management programs, innovation initiatives, workforce programs, metric improvement pilots, and RPU initiatives and programs. And in addition, $14.3 million was invested in IT infrastructure. Population health analytics. Investments in care management and population health systems allow 57 partners to aggregate Medicaid data. This information helps us better understand the health status of the communities and coordinate care. Convening and sharing best practices. We have convened over 160 partners, organized over 440 events with over 9,600 participants. Examples include stakeholder events such as this one, RPU-sponsored events and meetings, workshops, seminars such as the Kevin Hines seminar discussing mental health, palliative care events, regional trauma-informed care events, and nationally recognized experts such as upstreamist Dr. Manchanda and burnout experts Drs. Deschamps and Drummond. Also, we have surveyed and received input from over 550 Medicaid members. IT infrastructure, technology, and connectivities. $14.3 million has been invested in IT infrastructure, allowing partners to implement electronic medical records and participate in care management and population health platforms. The skilled nursing facility teleconsult program resulted in avoiding over 600 preventable hospitalizations. So important. And the COVID-19 Telehealth Assistance Program, or CTAP, invested $728,000, allowing 34 partners to deliver care remotely. And finally, workforce transformation, focused on the 5 pillars: recruitment, maximizing license and optimizing practice, educational alignment, training, and cultural competency and health literacy. There were 116 net new hires to this region. Also, CCN created a Train the Trainer program to support sustainable training across the PPS. 50 partners participated in SBIRT, motivational interviewing, and cultural competency and health literacy training. Next slide. So I would like to point out, before I go over this slide, at the beginning of DSRIP, the state average was 679 events per 100,000 population, potentially preventable readmissions. And the statewide goal by year 5 was 454 events per 100,000. Now, our PPS started with a baseline of 438 per 100,000, which is actually less than the overall 5-year state goal. So what I would like to say is that 12% decline is particularly impressive because it's much more difficult to reduce the numbers from such a low baseline. And you can see on the bottom how many Medicaid members, both in our region and in total, and how many of the total population were impacted. Next slide, please. So screening for clinical depression and follow-up. So this required documentation of a standardized screening for clinical depression, and if positive, documentation of appropriate follow-up care within 30 days. Now, what you can see here, and this is so impressive, the screening increased by almost 4-fold since 2015. And look at those numbers. 28,684 more people were screened among our attributed Medicaid members. And you can see the estimated numbers for total Medicaid members, total population. Next slide, please. Controlling high blood pressure. So this measure looks at patients with hypertension to evaluate if they are adequately controlled on their treatment regimen. And of course, this is so important. Hypertension puts you at risk for heart disease and stroke, and around 500,000 deaths annually in the United States included hypertension as a primary or contributing cause. Nearly half the adults in this country have hypertension, and only 1 in 4 of these people have it under control. So look at this, controlling high blood pressure increased by almost 2-fold since 2015. And again, look at the numbers, how impressive. In our region, over 28,000 more people had their blood pressure under control. Total Medicaid members estimated 65,000. Total population, 214,000 people in our region with their blood pressure under control, all due to our mutual efforts. Next slide. Integration of primary care and behavioral health services. So what I want to highlight on this slide and the next few slides, we really wanted to look at how did specific projects result in objective metric improvements and a direct beneficial impact on Medicaid members. And I think this says a lot more than just showing you a lot of spreadsheets and a lot of numbers. This shows the direct impact of what you specifically did. So integration of primary care and behavioral health services. So 27 partners provided over 99,000 services. So look at these important metrics, so important after an inpatient mental health stay for the patient to follow up. The 7-day metric was 20.5% increase from baseline, directly affecting 100 lives, and the 30-day metric was up 15.6% from baseline, also affecting about 100 lives. So important. Next slide. Strengthening mental health infrastructure. So here, 34 partners provided over 31,000 services. And if you look at the metrics below, these are metrics that reflect inpatient admissions. And also, if you look at cardiovascular and diabetes monitoring and schizophrenia, schizophrenics are, of course, prone to these, and the monitoring improved considerably from baseline. And also in terms of antidepressant medication management and ADHD medication follow-up, again, the numbers increased significantly. Next slide. So care transitions and COPD disease management, and this is what I really wanted to call out. So potentially preventable ED visits, which of course is one of the overarching goals of DSRIP. So there was an improvement of 3.9% from baseline. So the arrow points up, but what it really means is potentially preventable ED visits went down 3.9%, and it affected over 1,500 lives directly. And actually, I misspoke on the last slide. This is the slide that reflects inpatient admissions. And you can see in terms of hypertension, overall pediatric indicators, overall adult and pediatric indicators, percentage improved from baseline was considerable, and potentially avoidable readmissions 12.1%. So again, these numbers are so important and reflect the good work that's been done. Next slide. So here I would like to highlight programs that we continued and initiated as a response to the pandemic. And this utilized our existing interdisciplinary networks and our overall robust technology infrastructure. Next slide. Mark mentioned the telehealth program. So this involves skilled nursing facilities. We determined that there was a tremendous need for this, and this was our skilled nursing facility teleconsult pilot. So what happened here is we provided necessary infrastructure upgrades, telehealth devices and platforms, teleconsult services, both medical and behavioral. And these numbers are great. There were over 4,000 teleconsults, and out of these, about 60% of them, over 2,300, addressed off-hours patient change of condition. And those who are familiar with this scenario, you know how difficult it is off hours, first of all, to get a hold of a medical provider, and then just prevent that patient from being sent to the ED. And actually, out of all those teleconsults, over 600 directly avoided a hospitalization. Also, 41% of these consults were behavioral health scheduled, and we've gotten great feedback on that program as well. So we're continuing to evaluate the program, and actually at this point, 6 additional nursing facilities are in the process of implementation. Next slide. A couple other examples. Family Health Network is utilizing teleconsult to support primary care behavioral health integration as of August. Tioga County Mental Hygiene, similar to the skilled nursing facility programs, which started just before COVID, but were so important during COVID, they had a terrible no-show cancellation rate. And of course, the pandemic prevented in-person consultation, but this program had been rolled out, and there was actually a 13% decrease in combined no-show and cancellation rates. And Gerald's telemonitoring program, this just shows tremendous numbers. 113 members were enrolled, 100% actively engaged. And look at those numbers, 55% reduction in hospitalizations, 50% reduction in ED visits, 100% staff response to patient-triggered alerts within 2 hours, and 80% of the members achieving their care plan and social needs goals. Next slide. Transformation through telehealth, the CTAP program. So I am particularly proud of this program. And what this demonstrates is our agility in responding to an urgent crisis situation. So this program was conceived in mid-March 2020, open to receive applications on April 3rd. 2 rounds of applications were completed by May 8th, and all 34 applicants, I'm pleased to say, had their requests for assistance fully funded. Next slide. Now, what this slide illustrates, it's a little busy, but the takeaway point here is look at the funds distribution by organization type. So important. 42% mental health providers, 30% social organizations, 14% substance use providers, and very importantly, there are a lot of primary care physicians out there not affiliated with a medical group, not employed, and we help 14% of the funds went to help them. And if you look at the bottom, this is across our region. Next slide. So now I'd like you to please watch as several of our partners provide their perspective.
In working together to improve the health outcomes of our communities. It also helps to improve health literacy and reduce costs and enhance revenues for organizations. Back in 2015, our organization created a population health division to better understand the health needs of our communities and the patients that we serve. We collaborated with hospitals and primary care physicians, pulmonologists, nursing facilities, health homes, and other community agencies so that we could expand our respiratory, pharmacy, and home safety services. Our goal at that point was to engage and support people to take an active role in their own health and well-being and managing their respiratory conditions initially. We were looking to reduce readmissions and hospitalizations, and through the programs and working together collaboratively, we've seen about a 55% decrease in hospitalizations, a 50% decrease in ED visits, and we've also seen a dramatic improvement in patient engagement and self-management, which has led to them achieving more of their personal healthcare goals.
One of the ways that Casa Trinity experienced new relationships with our partners was really highlighted in the two projects I spoke of, the MIP and the cohort. The cohort project really brought all of the providers in the area to the same table. And so we partnered with Family Services and the YMCA for childcare, mental health, and also we partnered with a workforce development organization, so capabilities. Those three partnerships are partnerships that we didn't really have before this project. And they're partnerships that continue today. They're sustainable. They have learned, we've all learned to work outside of our silos and together to really create success for our members, our clients, the people that we serve. And, you know, a particular individual that we served in that project really couldn't make it to treatment, was overwhelmed, didn't have training for a job interview, didn't have the right clothing for the job interview. So all of the partners were able to come together and provide care for her in these ways. And so we got her a voucher for clothing so she could have the interview clothing that she needed. She was coached and trained on how to participate in an interview. And then she also had the childcare at the YMCA in order to have safe childcare so she could go out and start to work outside the home. And she's employed today. They're happy. She's completed treatment. Everybody came together to really lift up this member, this client of ours, for her to be successful, not only in her recovery, but down the road for her entire well-being.
It's helpful, I think, would be the collaboration and knowing that you have so many people to support you. One example is I was working with a female that was at the very bottom, deepest part of her basement, and with the help of Family Services, Catholic Charities, Casa Trinity, and capabilities, we were all able to watch her successfully and assist her with building her whole entire life over. So I often use her as an example because she had shared her testimony, so it's very in depth, but she didn't even know how to be a mom. So just being able to sit and have those conversations on top of being plugged into having a job and now having over a year and a half of sobriety and being able to know how to communicate better and just be given the tools from all areas of the community to support her with housing, with schooling for her daughter. It's great. Yeah, definitely that it's team, you know, it's collaboration, it's working together. It's not, well, you go over here, you know, and when you're done, come see me and we'll do our part. It's all working together with the local team as an effort. We all communicate. We were all getting together every week to case review and to see how we can further support these clients. And it was all collaborated. And that was by far the best experience ever because nobody was not on the same page. And we knew exactly where our clients were all the time with the different support systems that they had and what we needed to do to further support them in our area.
Gosh, there's so much for one, I'd like to resume our partnership because it was overall the collaborative effort was very helpful, and being able to share the collateral information with one another and all the partners was very helpful for us not to duplicate the services, and each of us will be able to, I guess, do their part as that specific service provider. So I would love to continue the collaboration. I would love for ACDC to continue in the cohort program. I don't know how we could expand on it, but I would love to continue being able to be a partner. We are working on the MediDecision platform, and basically it's tweaking the database toward our needs for housing. We meet weekly and we discuss what services we would like to see tracked, i.e. Discharge dates, entry dates, whether or not the person is covered, what kind of coverage, what services they are receiving while in the program, so that we can better track and possibly move towards Medicaid billing in the future. Right now, we work through HMIS for case notes and information sharing, but we like the service to better serve us to be able to track the population and stuff.
Powerful testimonials indeed. Now I'd like to highlight what I like to call our capstone, the cohort management program. Next slide. So here's a nice overview of the program. And as you can see, there are 18 networks of care organizing services around the needs of the Medicaid members, both clinical and social. And that's so important. So we had 70 total agencies, about 69% CCN partners, but also 31% non-partners. And you can see the effort stretched across our entire region and encompassed a wide variety of conditions: behavioral health, chronic conditions, gaps in primary care, multi-visit patients, et cetera, with a significant number of networks serving each area. Next slide. And here's just an overview of the 18 networks, a variety of lead agencies, everybody from Cayuga Medical Center to ACBC, Casa Trinity, Family Health Network, Gerald's, Guthrie, Lourdes, et cetera. And you can see the wide range of conditions and needs that have been dealt with: adult women with substance use disorder and trauma, behavioral health, ED visits, opioid use, childhood obesity and trauma, COPD and asthma in adults, opioid use disorder in adults, high emergency department visits. So you can see the wide variety and the depth and breadth of this program. Next slide. CCN provided funding for necessary services not previously funded through more traditional programs. So a standardized needs assessment was deployed across the region to identify social determinants of health needs and map interventions to clinical outcomes. And you can see on the right side the social determinants that rose to the top: transportation, both medical and non-medical, food insecurity, healthcare insecurity, medicine insecurity, and the list goes on. And on the left side, you can see the types of services that were funded. Next slide. So as a result of the cohort program, there was a total decrease in ER visits by 180 annually among 401 members in the program for 10 to 16 months. But it's not just about numbers, it's about people. And we can see a quotation at the bottom. Casa Trinity Case Management assisted me by helping me gain the coping skills that I have today to better communicate, stay sober, and has always encouraged me to put myself and self-care first, which I had a hard time doing because I always put everyone before myself. Next slide. This slide basically illustrates that hospitalizations did decline among most members who were engaged in the cohort program after just a few months. Next slide. So evidence would suggest that the networks have been successful, importantly, in connecting and engaging members to primary care services. There was an average increase of 931 primary care visits annually, among the 414 members from 1 to 6 months. And you can see similar results below. And again, it's about people. My case manager lifts my spirits, always takes me for coffee, listens to my situation, guiding me in a positive direction and connecting me to resources in the community to help me when needed. Next slide. So finally, these perspectives are from members of the Primary Care Advisory Council. So when I joined CCN, it was very clear that what we needed was primary care engagement in the process. And what we did is convene a group of clinicians from across the PPS meeting monthly to discuss their needs and the needs of the community. And really, it's delightful because it's organizationally agnostic. We really focus on our patients and our community. And the most gratifying aspect of all this has been the opportunity to hold a number of workshops where we promoted dialogue and understanding between these clinicians and our community partners. And I think there was mutual endorsement of this approach. So Dr. Cater from Cayuga, as we head towards value-based payment and pop health, it is essential that clinicians have robust working relationships with community-based organizations that can address the social determinants of health that the medical provider cannot. CCN has been at the forefront of facilitating these relationships with the benefit of comprehensive health management for the patient, more successful medical interventions, and cost savings for the entire system. Marita Florini, nurse practitioner, Ascension Lourdes. In a world full of technology, accurate communication is critical. The process by which we begin an aspect of care and bring it to completion must include robust communication, starting with the patients and caregivers, extended to all stakeholders involved in the experience. CCN has been a wonderful opportunity for this community to explore and implement new processes that use technology and old-fashioned in-person communication pathways to enhance care. Next slide. And finally, Dr. Masaryk from UHS. Partnership with CBOs is essential in primary care. The best thing to happen in my office was the addition of a care coordinator. I think CCN's biggest impact has been raising awareness of what is out there, facilitating interaction and contact between the medical side and CBOs, and just the overall educational piece to keep us informed of what is ahead. So again, this has been absolutely delightful, and we look to more engagement as time goes on. Next slide. And finally, I'd just like to close out with Dr. Therein, another member of the Primary Care Advisory Council, providing his perspective in the following video. Thank you all.
As far as care reform, working towards care delivery model changes, there's a lot at stake for primary care offices because these are the patients that we take care of. So any change in the payment model needs to be aware of the fact that there is risk associated with taking care of patients that that have these social determinants that mean they may not meet the normal measures that everybody likes them to meet as far as the quality criteria that are out there right now. That said, alternate payment models that may involve additional ancillary services provided through primary care, whether that means social work, whether that means connecting with local community health organizations, may make a huge difference for us in a way that is both direct and indirect, basically allowing us to continue to do the hard work of the medicine, which is sort of the routine health management, via giving support for all of the things that make those tasks more difficult, actually helps us attain the goal of health for the patient, to the effect of DSRIP's goal, things like that, to basically get those services into the community. It certainly is helpful for us to basically make sure that our patients are fed, clothed, that they have access to us, however that needs to be done.
We've come a long way, but we also have a long way to go. So we asked partners, what are you most looking forward to in the future? And again, partnerships, continuing the partnerships that have developed in acknowledgement that we need a critical mass in order to get payers to recognize the work and be willing to pay for the work that's been done. Sustainability, it has to do with not just sustainability of CCN, but sustainability of each individual organization, your continued participation, and the work that's being done collectively. There is work to be done to continue to make the transformations that we began. We need to create the value proposition for CCN. We need to continue to work together. And for that, we need your continued participation. So I invite you to stay with us. Again, let me introduce another partner's perspective on this.
So this partnership came up with the 911 Distress Caller Diversion Program. It's the first of its kind in New York. It allows dispatchers to use a risk assessment tool to gauge the acuity of the crisis and determine if it's safe to transfer the call to a crisis call taker as opposed to sending the police. This process has been recognized and published in CIT International's Best Practice Guide. So I'm so proud of our partners in Broome County and Care Compass for developing this and coming up with this program. You know, there's never been a more important time to not cut funding to mental health services. As if a pandemic itself is not bad enough, the lasting effects are likely to be around long after the vaccination. Anything from children lacking socialization to parents working full-time while schools are remote, to the economic impact and job loss, not to mention the increase in domestic violence and you know, the potential increase in incarcerations, homelessness, and anxiety and depression. This virus is likely to have a lasting effect that far exceeds the life of its strain itself. So the struggle's real. Resources that are available 24/7 is the biggest challenge, particularly when you're talking about first responders. Crisis doesn't have a time clock. And when you're talking about first responders and having the ability to access programs after hours is a significant piece of avoiding hospitalizations. And I think that there may be an opportunity on the emergency services side for ambulance services to become involved in value-based payment.
I think that the care management platform is a real opportunity for us to think about, not only as us as an organization, but us as a region, as partners, to think about the way that we do data sharing between organizations in support of the clients or the patients that we're serving. Care management platform, I think, is a real opportunity for us to figure out how this works for us, both locally and regionally. How do we collaborate in this way safely and effectively? What are the things that work well and what don't? How do we get ourselves as organizations and as partners situated so that in a value-based world, we have this kind of part of it down pat? And so I think that the care management platform really provides that opportunity to get started with that, to figure out what we need to be doing differently, what we can be doing more collaboratively, and providing us with the support and the technical assistance, whether it's from Care Compass staff or from consultants that Care Compass has retained, to be able to figure out how to do that as a community-based organization. The work that Care Compass is doing, because talking about how data sharing can be better, talking about how information be collected more rapidly and shared more rapidly and used for decision making is a big piece of what we've been talking about with Care Compass. So that's just become so clear that we can't be relying on 3-year-old health information anymore. We've got to do better because things are changing really fast, and we can adapt our services. We can change what we do quickly. We saw the whole country changed how it works very quickly. So we can do that. It's sure hard, but we can do it. And if we have good information and good data to be able to inform that, we're really in a much better place than if we're using really old information. So I see that as a real area of potential growth, both for Care Compass and all of us, to think about how we can use our information more efficiently and quickly. But it was the relationships between the organizations and the people that allow you to have the trust to move forward with some of these big changes that you're doing. Because if you don't have that baseline to trust that your partner will live up to their side of the project or the agreement, then it's hard to move forward. And so, Care Compass as a convener, a facilitator of those relationships, really has an opportunity, I think, that's exciting to continue to build on those as we move into the future.
I guess I would ask the question, why have we made this investment in reform if we're not able to follow through and see it to its logical conclusion? So I'm looking forward to a regulatory environment that supports what so many of us have spent 5 years working towards. The past 5 years and the really extraordinary leadership of Care Compass Network in bringing together community partners with clinical partners has laid the foundation for the future. And again, I think if we can operate in an environment that supports value-based payment at scale, which is really important. We have some value-based payment mandates currently from the state for Medicaid managed care that frankly are not at scale, at least when you're looking at your community partners. But if we can get to that point, Care Compass Network has positioned Rural Health Network of South Central New York and many other partners for success in networking and value-based payment. The cohort program was a really strategic, smart investment in learning how to do networking, significant success. And I think we know how to do it now. I really do. I think all we need, again, is an environment that supports those of us who want to work together on the community and the clinical side to come together and to deliver the highest quality level of both social and clinical services to those who need them. So, yeah, I think enough said. I think Care Compass Network has positioned us for success, and now we need the public policy piece that allows that success to really move forward and become institutionalized or standardized.
We've started to participate in the value proposition work with Care Compass Network. It's really aligned nicely with our organization's future strategy development. It's really helped us to sit back and analyze our structure and create goals and action plans that focus on spotlighting our value-added services and what our core values really are. We're known as a DME and a pharmacy, but our organization has really developed into a holistic patient-focused or patient-conditioned organization versus a prescription-focused organization. And that's our value add. And what we hope to do with that beyond Disrupt is to continue our partnerships and seek out opportunities that exist with other primary care providers and organizations, community agencies, and of course the payer sources, so that we can sustain the great programs that have been developed and continue in our efforts in improving the outcomes for those with chronic conditions. We've certainly seen over the past few years where our referrals have now, we're receiving referrals at earlier stages of disease, which is really key. Our ultimate goal is to be able to receive referrals and start educating these patients at the time of diagnosis, so that they're better able and better equipped to manage their conditions. So working with the proposition team at Care, the value prop team at Care Compass Network has really helped us to realize that that's what we really want to focus on as far as our core values and market that along with our other supportive services.
So I think what was most rewarding and remains most rewarding is the commitment that people seem to have to achieving the vision that's underpinning Disrupt and now underpinning our future. And we have had people in our strategic planning committee coming forth weekly or bi-weekly for 2-3 months to build out the future plan. And it just amazes me that they come forth every week with a full plate of things to do elsewhere, but they're still 100% committed to this.
We're back. Hi, everyone. I think that's a good segue for some strategic planning. And I just want to appreciate everybody's time on joining us to record those videos. Not everybody can be at every single meeting, so it was a great way to hear from the partners. But I think it demonstrates something that that we heard from Robin in a previous video session that every partner has a voice. And I think you feel and sense that as we go through this. We really do value the voice of the partner. In fact, it's critical because we need to understand what's happening in the region as we develop and deploy, whether it's projects or initiatives or whole strategies. So what I wanted to do is take a moment here and talk about strategic planning and give everybody an update on some things that have been moving the past few months. For one, we leverage a partner-facing strategic planning work group. So this is a few of them that have joined us. So as Robin stated, thank you so much for your dedication to join us and continue with some of the planning. We can go to the next slide here. We do have a mission statement. And I think what I've stated previously is that Care Compass Network, when we formed this, we didn't box us into the DSRIP program. We knew that this time was coming, that the DSRIP program would end at some stage, and we didn't want to exclude the future potential for growth. So we said a few things in here about wanting to support enduring partnerships with clinical and community partners towards the purpose of a VBP environment, but we didn't box it exclusively into DSRIP or projects or Medicaid or 9 counties or speed and scale and all the things that we've been doing the past few years. We can go to the next slide. Where we ended up with strategic planning was something we've been sharing for a while. It's called Vision 2025. And as we exit 2020, we'll officially be exiting Vision 2020, our previous strategic plan, and we'll be much more dedicated and solely focused on Vision 2025. And there are 3 core elements of this plan that were highlighted by our strategic planning group and approved by our board back at the end of 2018, believe it or not. For one, what a lot of the partners have recognized in their testimonials throughout this call is a convener. We really need to see CCN continue to serve the role as a convener of stakeholders. We have to uncover who's in the community, who's doing what are the opportunities to form networks and those sorts of things. Especially we found when COVID came out in March and April, our RPU meeting attendances in some cases doubled. The partners wanted to have a forum to come together and hear what was going on at other locations and share best practices. So that's something that we're going to continue in the future. And even this meeting, a quarterly all stakeholders meeting, is something that we have in plan. But we want to see how can CCN support network formation and network operations. And what we learned in the cohort program is those are 2 very distinct, very separate initiatives. It's one core initiative to form a network or support the formation of a network, completely different to support the ongoing operational needs of networks. So we want to see CCN support those initiatives and also continue to be a catalyst for innovation. We have a lot of white papers, we have lunch and learns. There's going to be a lot of things that we push to promote the sharing of best practices and the continual innovation across our partners in the region. Now, the next few slides are going to focus in on how do we look to achieve that. So we can go to the next slide. Perfect. For one, there are some organizing elements around this vision statement. So as we started planning, we really said, what are the high-level objectives as we walk through this? Well, one, we want to functionally prepare and organize our partners and ourselves for participation in value-based arrangements. As we go into that, we know that there's going to be a strong need to design and implement a data platform to capture relevant data to inform our performance and supply data at the point of care. We have a lot of systems. We've modified and used those systems to measure our performance in the DSRIP program, measure our performance on DSRIP metrics, prioritize metrics for DSRIP funding and other purposes, and even evaluate the outcomes of some of our projects. Now we want to start to deploy those systems for this purpose and outcome. We want to see productive partnerships with those who pay for care formed. We want to see CCN services sustained. We want to see a lot of the innovation and cohort programs that our partners have developed be sustained. And that gets into the last piece, which is a lens of sustainability. So those are some of the high-level principles, I'll call them. We can go to the next slide, around Vision 2025. As we go into the guiding principles a little bit more in detail, we are at a stage where we really need to be grounded in fact. This was something our strategic planning group mentioned in the very first meeting that we had earlier this year. They said, we've been doing this for years. We have experience. We have the ability to measure projects. We have the ability to measure partner performance. We have the ability to even look at new market studies and understand what are the current needs of the Medicaid member. So as we move forward and make decisions on program extensions and all those sorts of things, we want to be grounded in fact based on our past performance. We also want to be able to show our impact. And in order to do that, we have to really engage more progressively in data sharing. It's very intentional, it's very specific, it's very targeted. But as several of the partners mentioned, we're now tracking and monitoring this, and it's changing our ability to build our value proposition. A big theme of today's discussion was actually integrating the social and clinical care approach. But also we want to identify those new revenue sources. We want to see how we can change the discussion with the payers, represent the organization at large, and be able to show and package the great work that our partners have done, and also find new areas where we need to formally advocate at different levels. It could be at the local, the state level, but there's a lot of work and positioning that we can do to help make sure that our region and accomplishments have maybe at times the proper red tape or barriers removed. So we can go through the next slide. What was a very recent development in the October Board of Directors meeting, we had the next level down, Vision 2025, was just recently approved. So I think this is our first time taking this to the stakeholder group. We have 4 high-level goals. I overviewed these on the previous stage, but we now have sub-strategies on how we want to achieve those goals. So for those of you that were on any one of our project advisory teams, this is starting to look and feel very much like our original district application. We have milestones, we have initiatives, we have deadlines that we're looking to set. I won't go through these in detail. Like they said, the slides will be available online, but we've been working to see not just what are the goals, what are the sub-strategies that are going to take us there, and begin to sequence those over the next few years. So these goals are approved by the Board of Directors. So a big thank you to the Strategic Planning Group who helped frame this up, and also to the board for the dedication and time to review and give us some thoughtful input to it. We'll go to the next slide here. So a big theme as we transition. Care Compass is transitioning away from Vision 2020 into Vision 2025. We're transitioning out of the district program. We've satisfied our objectives. So the state does continue to make ad hoc requests and data submissions. We continue to meet those. But in the principle, let's say from a funds flow perspective, we had a very prescriptive roadmap under the district program. We had projects, we had data reporting expectations, we had data reporting deadlines, we had speed and scale requirements. The state at times even mandated how you could navigate or how often you could navigate or how often you could treat an individual. So it was very, very prescriptive. We had IT infrastructure. It was regardless of participation with CCN and other initiatives. If you were safety net, we wanted to get you Rio connected. I mean, we had very broad scale initiatives on the district program. Where we're moving in Vision 2025 is to be much more targeted. We want to sustain the promising practices that are likely to be sustainable. We want to target initiatives for continuation based on demonstrated impact. We'll find ourselves doing things like prioritizing. CCN does have some resources, but they're not infinite. So we want to see how do we prioritize and sequence future investments and initiatives that we make into the future. And some of that might be additional network infrastructure. And I say network in the sense of we, the community, are a collective network working together. And there might be needs that are inherent to that network as we march forward in steps towards value-based payment. And also identify eligibility criteria, requirements for partnership. So one of the things that mentioned earlier was data partnership. But if we can't measure the outcome, it makes it much more difficult for us to prove the value. So these are some of the concepts that are being worked out, but I think it goes from broad and open to focused and intentional. And that's a big theme of where we're trying to move into the next performance cycle. So we can go to the next slide. So this is a little bit of a deeper dive on just the evaluation piece. We want to assess what are the current needs, what's the current market, what's the community need perspective, what's the current payer landscaping, identify where are potentials for sustainability in the future. We want to evaluate our past performance. A lot of initiatives. The Pop Health team at CCN has been very busy identifying some of those things. And we need to, as an organization, develop a holistic budget. CCN itself is shifting outside of grant administration, and we have a little bit of a runway that we've afforded, but we need to create a budget that allows us to wean off of district funding and transition into sustainability funding. And that might include, like I mentioned, investments in network infrastructure, continuation of programs, and those sorts of things. And then we have to do a massive integration of those things to help us guide and inform decision-making. So we can go to the next slide here. Perfect timeline. So this is actually just reviewed and endorsed at our last board meeting, which was Tuesday of this week. So this is as new as information can get. We said there's a lot of due diligence that goes into framing up the next phase of CCN partner engagement, I'll call it. And these are some of the core domains. And what we did was we set out due dates for each of these, and I'll walk down these one by one. So major activity number one, assess the community need and the payer landscaping. That has an end of January deadline. Our evaluation of program and partner performance is end of December. And also identification of requirements for new performance contracts, Appendix Cs, or new engagement models. Those engagement criteria would be by the end of January. And it's those first three items that we're going to look at all together to really identify what is the long-range CCN budget. We do have some legacy district funds. When are we going to deploy those by? Start to identify what types of things are we going to use that to make investments in. And as we move beyond that, item number 4, this is a way of, I think, articulating the cohort program. We want to develop experiential pathways. And that's what the cohort program really did. It allowed us to learn what does it take to be a VBP lead contractor? What does it mean for us to integrate services with common agencies across the community? What does it mean for us to operate as a network? There's network formation and network operations, two critical skill sets towards operating and thriving in a VBP environment. And we want to continue to make experiential pathways available to our partners. We also want to, number 5, and this is more future facing, so you can see we'll start to explore this towards the midpoint of Q1 next year. Determine factors for partner readiness and recruitment of the network. We have a network that was formed for district purposes. That's a performing provider system, a PPS. Part of our strategic plan looks at organizing around value-based payments. And so we might start to look at what is partner readiness, what are partner requirements, and what would recruitment of that network start to look like. So we'll engage and have those discussions next year. And then we also, in the scope of our strategic plan, we have a vision, we have strategies, we have goals. We also have very detailed, this is ground level, initiatives and actions. And the leadership team has been working heavily to form this, identify forks in the road. And we want to engage the strategic planning work group in January to identify where are key decisions, what are some principles and new foundations that we're setting, and make sure that we have community input, as we've always done, with how we make critical decisions as we march forward. So these are some key dates. These are, the board's reflection was that this is massively aggressive. We don't know yet how organizations may be impacted from post-holiday surges and things, but we do have the encouragement to try to be aggressive in the January timeframe and the remainder of December so we can start to come out with new plans, initiatives, and continuation in Q1 of next year. So I believe that wraps up the slides here, and we were going to go on to another partner testimonial.
Nothing builds a bond more than investing that kind of energy, talent into the process. And that same investment is occurring today.
I am constantly bragging about the relationships that CCN has very, intentionally developed throughout our region. And oftentimes my colleagues, network directors from other areas of the state, are honestly jealous. They're frustrated sometimes that their PPS has not been as visionary as ours, that it has not provided, sort of the same opportunities, if you will. And in learning from them, their experiences, some have had some good experiences, but I don't think that any of them have had the degree of experiences, the breadth of, involvement in programs. And I think that when we all look at the future, with the change in the way in which we pay for healthcare, in which we manage healthcare, some of those discussions perhaps don't go totally in depth at the board level, but I think that when you know that it requires systemic change at both the institutions as well as community-based organizations and even down into provider practices, the board, being on the board has really provided an opportunity to get a little more in depth and to be able to understand, how each of the other components of the system overall have to address this. So that's been wonderful. And I think as a board member, the model here slightly differently. For example, my agency, our board of directors is extremely involved, in the strategic planning. And, here what we've done is convened, a mixture of a group, partners, staff, some board members, who have spent a great deal of time, down in the deep dive for the strategic plan, all of it routinely communicated to the board, ultimately endorsed by the board. But the board then has the opportunity to really ask probing questions from almost, if you will, an objective manner, because most of them weren't involved in those, very intensive meetings that we had. So to be able to be at that level and to really think from, sort of that, higher level about the future of CCN, I'm just thrilled to be a part of it. And I think that we're going in a really good direction.
Hi, we may go over the allotted time by about 5 minutes, so any questions you have will be answered through CCN website after the meeting. I know that Kathy Connerton wanted to be here to make a few closing remarks, but she got called away. I know that from her comments before the meeting, the hospital systems are involved in discussions about vaccine distribution. We normally at our December meeting provide food for all the participants of the meeting, but times have changed. We're meeting by Zoom, and because of the pandemic, we know that food insecurity has really increased significantly. So in honor of our partners and community residents, Care Compass Network did make a donation to 4 food organizations, one in each of the RPU, to help address the food insecurity in our 9-county region. So thank you, Care Compass Network, for that donation. Finally, I just want to thank everybody who participated in putting this presentation together. But more significantly, I want to thank all of you, all your organizations, for your hard work the past 5 years. It's been a journey. The journey will continue, and we look forward to your partnership and participation in the coming years. The work of healthcare transformation we knew could not be accomplished in 5 years. And so it's important, it's essential that we continue on this journey. It's already proven its value in improving the health of individuals and the public health across our whole region. So see you next time. Just two housekeeping things. The next stakeholders meeting will be in March 12th. And also don't forget to fill out the evaluation that you will receive after this presentation. So thank you, everybody, and happy holidays and stay healthy.